Welcome, future nurses. My name is Mark Johnson. I'm an NCLEX instructor and an ICU nurse. And today we are tackling one of the biggest hurdles in nursing school, pharmacology. My goal is to help you stop memorizing and start understanding. I want you to actually get why medications work the way they do, how they move through the body, and how to recognize patterns that will make this content stick, not just for the exam, but for real-life nursing. Pharmacology is huge, I won't lie, but it doesn't have to be overwhelming. When you break it down, it's manageable, and honestly, even kind of fun once it starts to click. This NCLEX Pharmacology Mastery course will consist of 15 topics. Introduction to Pharmacology, Autonomic Nervous System, Medications, Cardiovascular Medications, Respiratory Medications, Corticosteroids, Anticoagulants, and Antiplatelets, Pain, Sedation, and Anesthesia, Endocrine Medications, Gastrointestinal Medications, Infectious Diseases Medications, Emergency and Critical Care Medications, Psychotropic Medications, also known as mental health meds, reproductive and genitourinary medications, miscellaneous must-know medications, and finally, we'll wrap it up with NCLEX-style practice questions. And if you want to follow along this lecture with the detailed and visual notes, check out our Pharmacology Mastery notes on our website, yournursingspace.com. Let's start at the foundation, how medications move through the body and how they produce their effects. This brings us to two key concepts, pharmacokinetics and pharmacodynamics. First, pharmacokinetics. It's the journey of a drug through the body. Pharmacokinetics is what the body does to the drug. The process follows 4 key steps, which we remember with the acronym ADME: absorption, distribution, metabolism, and excretion. Let's go through them one by one. Absorption is how the drug enters the bloodstream. This depends on the route of administration. For example, drugs given by IV go directly into the bloodstream. That's the fastest method. Oral medications, or PO, take longer because they have to go through the digestive system first. They're absorbed through the stomach or intestines and then processed by the liver. That leads us to the first pass effect. This only applies to oral medications. When a drug is absorbed through the GI tract, it first goes to the liver. The liver may metabolize a portion of it before it ever reaches circulation. That reduces the drug's bioavailability, which we'll talk more about later. Distribution is how the drug travels through the bloodstream to reach the tissues and target organs. One major factor here is protein binding. Some drugs bind tightly to plasma proteins, like albumin. If a drug is highly protein-bound, it stays in the circulation longer because only the unbound portion is active. Warfarin is a perfect example. It's about 99% protein-bound. That's why it interacts easily with other drugs that are also protein-bound. Small shifts can lead to big effects. Metabolism, or biotransformation, is how the body breaks down the drug, mostly in the liver. The liver uses enzymes, especially the cytochrome P450 system, to break down many medications. If a person's metabolism is slow, the drug can build up in the body over time. That leads to a higher risk of toxicity. On the flip side, if metabolism is too fast, the drug may wear off before it has time to work. Excretion is how the drug leaves the body. Most drugs are excreted through the kidneys, so we always want to monitor creatinine and BUN levels to check kidney function. In patients with kidney disease, drugs may not be eliminated properly, they can accumulate, which increases the chance of side effects or toxicity. Quick recap. The 4 steps are absorption, distribution, metabolism, and excretion. That's ADME. I like to remember it with the phrase, a drug must exit. Now let's switch gears. Pharmacodynamics is what the drug does to the body. This is where we talk about mechanisms of action, how drugs produce their intended effects. The most common mechanism is receptor binding. Drugs can either activate receptors or block them. When a drug activates a receptor, it's called an agonist. An example is albuterol, which stimulates beta-2 receptors in the lungs. This opens up the airways and helps patients breathe easier. On the other hand, when a drug blocks a receptor, it's called an antagonist. A good example is a beta blocker, like metoprolol, which blocks beta receptors and slows down the heart rate. Another important concept is the therapeutic index. This refers to the safety margin of a drug. A drug with a narrow therapeutic index has a small window between the effective dose and the toxic dose. That means we need to monitor those patients closely. Let's go over a few more terms that are frequently tested and highly relevant in practice. First, half-life. This is the amount of time it takes for half the drug to be eliminated from the body. If a drug has a short half-life, it leaves the system quickly, so it may need to be taken more often. If it has a long half-life, it stays in the body longer, which means we can space out the doses. Next is bioavailability, which we touched on earlier. This refers to the percentage of a drug that actually reaches the circulation and is available to do its job. Because of the first pass effect, oral drugs often have lower bioavailability than drugs given by IV. Now let's look at drug classifications and those magic little suffixes that help you identify what kind of medication you're dealing with. Let's go through a few of the most common ones. Drugs that end in pril are ACE inhibitors, like lisinopril, which are used to treat hypertension and heart failure. LOL means the drug is a beta blocker, like metoprolol, which are used for high blood pressure and arrhythmias. Check the table in the notes for more examples. Knowing these suffixes helps you quickly identify the drug class, its use, and often its most common side effects. Controlled substances are categorized based on their potential for abuse and addiction. The schedule runs from 1 to 5. Schedule 1 drugs are illegal. They have no accepted medical use. Examples are heroin, LSD, and ecstasy. Schedule 2 drugs have a high abuse potential but are used medically. This includes morphine, oxycodone, and Ritalin. Schedule 3 drugs have a moderate risk of abuse. Examples include codeine and ketamine. Schedule 4 drugs have low abuse potential. This includes benzodiazepines like Xanax and Valium. Schedule 5 drugs have the lowest potential for abuse. Examples are cough syrups that contain codeine. To help remember this, try the mnemonic. I am the fighting nurse. I for illegal, A for addictive, T for therapeutic, F for few risks, N for not a big deal. Let's talk about pregnancy safety categories. These range from A to X. Category A is the safest. There's no risk to the fetus in human studies. Examples include folic acid and levothyroxine. Category B shows no risk in animal studies, but there are no well-controlled studies in humans. Examples are amoxicillin and Zofran. Category C shows risk in animal studies, but the benefits may outweigh the risks. This includes fluoroquinolones and SSRI medications. Category D has evidence of fetal risk, but the drug might still be used if the benefits outweigh the dangers. Examples are ACE inhibitors and phenytoin. Category X means absolutely contraindicated in pregnancy. These drugs cause fetal abnormalities and should never be used. Examples include warfarin and isotretinoin. All right, let's jump into the autonomic nervous system, or ANS for short. This system controls the stuff your body does automatically. Think of things like heart rate, digestion, breathing, urination, and blood pressure. Basically, all the behind-the-scenes action that keeps you alive without you even thinking about it. The ANS has 2 major branches. Let's break them down. The first is the sympathetic nervous system. This is your fight-or-flight response. When it's activated, your body gets ready to defend itself or run like crazy. It increases heart rate and blood pressure, opens up your airways, shuts down digestion and bladder function, and gets energy ready for use. The second is the parasympathetic nervous system. This one's your rest and digest mode. It does the opposite. It slows your heart rate, brings your blood pressure down, and ramps up digestion and urinary activity. It conserves energy and keeps things calm. Now let's look at how medications interact with these systems. Adrenergic agonists activate the sympathetic nervous system. That means they increase heart rate, raise blood pressure, and open up the lungs. Here are some examples and what they're used for. Epinephrine is used for anaphylaxis, cardiac arrest, and shock. It raises the heart rate, increases blood pressure, and causes bronchodilation. It's a lifesaver, literally. Albuterol is a rescue inhaler used in asthma. It works by opening up the airways fast. Dopamine is used in shock and heart failure. It helps raise blood pressure and improves kidney perfusion. Phenylephrine is used for nasal congestion and low blood pressure. It causes vasoconstriction. As for nursing considerations, always monitor blood pressure and heart rate. These drugs can easily cause hypertension and tachycardia. Be careful in patients with heart disease. These meds increase cardiac workload. And with albuterol, watch for tremors and palpitations. Those are common side effects. Here's a helpful tip. Alpha equals arteries. Beta equals beats and breathing. Alpha 1 agonists constrict blood vessels and raise blood pressure. Beta 1 agonists increase heart rate and force of contraction. Beta 2 agonists open up the lungs through bronchodilation. All right, next up, we're talking about adrenergic antagonists, also called sympatholytics. These drugs do exactly what the name suggests. They work against the sympathetic nervous system. So instead of revving up the fight or flight response, like adrenergic agonists do, these drugs hit the brakes. They block alpha and beta receptors, which leads to lower heart rate and lower blood pressure. Let's start with the alpha blockers. These drugs end in zosin. Two of the big names here are prazosin, which is used to treat hypertension and sometimes benign prostatic hyperplasia, or BPH, and tamsulosin, which is more selective for the prostate. It's commonly used to treat BPH, helping to relax the muscles in the bladder and improve urine flow. So if you think of alpha blockers, just remember, they open up the blood vessels and relax the smooth muscles, especially in the urinary tract. Now let's move on to beta blockers. Beta blockers are split into two categories, selective and non-selective. Selective beta blockers like metoprolol and atenolol mainly block beta-1 receptors in the heart. These are used for high blood pressure, angina, and heart failure. Because they focus on the heart, they're generally safer for patients with asthma or COPD. On the other hand, non-selective beta blockers block both beta-1 and beta-2 receptors, so they affect both the heart and the lungs. Examples include propranolol and carvedilol. These are used for things like hypertension, anxiety, and migraine prevention. But you want to be careful in patients with respiratory issues because blocking beta-2 receptors can cause bronchoconstriction. Let's talk about the key nursing considerations for all beta blockers. First, always check the patient's heart rate before giving a beta blocker. If the heart rate is less than 60 or the systolic blood pressure is below 100, hold the medication and notify the provider. Second, do not stop beta blockers abruptly. Stopping suddenly can cause rebound hypertension and tachycardia, which can be dangerous, especially in cardiac patients. And finally, if your patient is diabetic, monitor them closely. Beta blockers can mask the symptoms of hypoglycemia. That means they might not feel the usual warning signs like shakiness or palpitations. Always make sure they're checking their blood sugar regularly. All right, let's move into cholinergic agonists, also known as parasympathomimetics. These drugs stimulate the parasympathetic nervous system. And remember, that's your rest and digest system. So what happens when these drugs kick in? They help the body relax, they increase secretions, slow down the heart rate, and promote digestion and elimination. They do this by acting on muscarinic and nicotinic receptors, which are located all over the body, from the heart to the GI tract to the brain. Let's walk through the most common cholinergic agonist drugs and what they're used for. Bethanechol is used for urinary retention. It stimulates bladder contraction and helps patients urinate. Pilocarpine is used for glaucoma and dry mouth. It increases fluid drainage from the eye and also helps produce saliva. Carbachol is another glaucoma medication. It works similarly by reducing intraocular pressure. Then we've got a group of drugs used for neurological conditions. Donepezil and rivastigmine are used in Alzheimer's disease. They work by increasing levels of acetylcholine in the brain, which can help with memory and cognitive function. And for myasthenia gravis, we have pyridostigmine and neostigmine. These drugs improve communication between nerves and muscles, boosting muscle strength. Now here's where you need to be careful. If too much acetylcholine builds up in the body, we can see a cholinergic crisis. And that's not fun for anyone. To remember the symptoms, use the mnemonic SLUGE and BBB. Cholinergic agonists make everything wet and slow. Here's what that stands for. S, salivation L, lacrimation, which means tearing, U, urination, D, diarrhea G, gastrointestinal upset, emesis or vomiting, and the three Bs, bradycardia, slow heart rate, bronchoconstriction, narrowed airways, bladder contraction, increased urinary urgency. If your patient is showing these signs, it might mean they're having a cholinergic crisis. The antidote is atropine. It's an anticholinergic that blocks the parasympathetic system, reversing symptoms like bradycardia and excessive secretions. Let's go over a few nursing considerations for these meds. Bethanechol should be taken on an empty stomach to reduce nausea. Pilocarpine should be used cautiously in patients with asthma or COPD because it can cause bronchoconstriction. Donepezil is best given at bedtime. That helps reduce dizziness during the day. With neostigmine or pyridostigmine, watch closely for muscle weakness. If the dose is too low, the patient might be in a myasthenic crisis. If it's too high, they could go into a cholinergic crisis. Both conditions cause weakness, but one needs more medication and the other needs less. That's where close monitoring and clinical judgment really matter. Now that we've talked about cholinergic agonists, let's look at their opposite, cholinergic antagonists, also known as anticholinergics or parasympatholytics. These drugs block the parasympathetic nervous system by inhibiting acetylcholine receptors. And when you block the rest and digest system, you get the opposite effects. You see an increase in heart rate, bronchodilation, drying of secretions, and urinary retention. Let's walk through the most common medications in this category and their uses. First up is atropine. This is a go-to emergency drug used to treat bradycardia or a dangerously slow heart rate. It also dries secretions before surgery and acts as the antidote for organophosphate poisoning, which is something we rarely see. But it's still tested on NCLEX. Next is scopolamine. This one's great for motion sickness, and like atropine, it's also used to dry up secretions before surgery. It comes as a patch you apply behind the ear, and it needs to be replaced every 72 hours. Ipratropium and tiotropium are commonly used for COPD and asthma. These meds help with bronchodilation and reduce mucus production. Just remember, they are not rescue inhalers. They take time to work, so they're more for maintenance than immediate relief. Oxybutynin and tolterodine are used for overactive bladder. They relax the bladder muscles, which helps prevent frequent urination. These are super helpful, but they should be avoided in patients with BPH or benign prostatic hyperplasia because they can make urinary retention worse. Benztropine and trihexyphenidyl are used in Parkinson's disease. They help reduce tremors and muscle rigidity by restoring the balance between dopamine and acetylcholine in the brain. However, be extra cautious with elderly patients since these drugs can cause dizziness, confusion, and increase the risk of falls. And finally, we have dicyclamine, which is used for irritable bowel syndrome, or IBS. It helps reduce bowel spasms, making it easier for patients to manage painful cramping. Now let's talk about what you really need to watch for, the classic anticholinergic side effects. We remember them with the phrase can't see, can't pee, can't spit, can't shart eat. That means blurred vision, urinary retention, dry mouth constipation. Basically, everything dries up and slows down. So what are the key nursing considerations? For atropine, always monitor the heart rate. Too much can lead to tachycardia, and avoid it in patients with glaucoma because it increases intraocular pressure. With scopolamine, make sure the patch is applied correctly behind the ear and that it's replaced every 72 hours. For ipratropium and tiotropium, remind patients that these are not rescue inhalers. They won't work for an acute asthma attack, and they need to be taken regularly to be effective. With oxybutynin, avoid giving it to patients who have BPH, since it can worsen urinary retention. Benztropine requires caution in older adults, especially due to the increased risk of confusion and falls. Here's a quick mnemonic to tie it all together. Anticholinergic means anti-chill. These drugs dry everything up. So again, can't see, blurred vision, can't pee, urinary retention, can't spit, dry mouth, can't tea. Constipation, simple, easy to remember, and definitely testable on the NCLEX. All right, now that we've covered the basics of pharmacology, from the intro all the way to autonomic nervous system meds, Let's switch gears and do a little NCLEX style practice. Nothing too intense to start with. We'll warm up with some easier questions and then ease into the trickier stuff. Sound good? Okay, question 1. Which pharmacokinetic process is most directly affected when a patient has liver dysfunction? A. Absorption. B. Distribution. C. Metabolism. D. Excretion. And the answer is C. Metabolism. The liver is like the body's processing plant for drugs, and if it's not working properly, drugs can stick around longer than they should, and that raises the risk of toxicity. So, yeah, liver equals metabolism. Next up, a patient has developed a tolerance to a drug. What change is expected in its pharmacodynamic response? A. Increased therapeutic effect. B. Decreased response at the same dose. C. Enhanced drug absorption. D. Reduced drug metabolism. Answer is B. Decreased response at the same dose. Basically, the body's like, been there, done that, and doesn't react the same way anymore. This happens when receptors become less sensitive, so you don't get the same effect without increasing the dose. Moving on. A patient with chronic hypertension is prescribed albuterol for asthma. The nurse should monitor the patient for which potential interaction between albuterol and their beta blocker, say metoprolol. A. Increased risk of hypotension. B. Decreased bronchodilation effect. C. Excessive central nervous system stimulation. D. Severe bradycardia. Answer is B. Decreased bronchodilation effect. Albuterol works by stimulating beta-2 receptors to open up the airways. But beta blockers can block those same receptors, especially at higher doses, even if they're selective. So you've got one drug trying to open the airways and another blocking that signal. Not the most cooperative combo. Next question. Which clinical finding best indicates anticholinergic toxicity in a patient taking benztropine for Parkinson's disease? A. Bradycardia and constricted pupils. B. Dry mouth, confusion, and urinary retention. C. Lacrimation and bradycardia. D. Nausea, vomiting, and diarrhea. Correct answer, B. Dry mouth, confusion, and urinary retention. This is your classic anticholinergic overload. If you've ever heard the saying, dry as a bone, mad as a hatter, full as a flask, this is what they're talking about. Dry mouth, mental fog, and that lovely inability to pee. Last one. A diabetic patient is prescribed propranolol. What's the most important adverse effect the nurse should monitor for? A. Hyperkalemia. B. Reflex tachycardia. C. Masked symptoms of hypoglycemia. D. Increased insulin sensitivity. Answer. C. Masked symptoms of hypoglycemia. Propranolol blocks beta receptors, including the ones that help the body respond to low blood sugar. So those usual warning signs like shaking or a racing heart, they might not show up. Kind of scary, honestly, because the patient might not even know their sugar's crashing. The only sign that tends to stick around is sweating. All right, that wraps up part 1 of our Pharmacology Mastery series. If this helped you out, don't forget to subscribe and hit the notification bell so you catch part 2 and all the other good stuff coming your way. Again, if you're looking for this Pharmacology Mastery Notes, they're ready for you on our website. You can also check out our test bank platform, Exam ASAP, our advanced adaptive testing platform featuring over 5,000 peer-reviewed questions designed to mirror the NCLEX experience. It includes detailed rationales, daily content updates, and a 24/7 AI tutor, resources recognized as industry-leading and proven to enhance your performance. Not only that, our question bank platform has next-generation NCLEX question types with case studies. We are adaptive and AI-powered platform that allows you to pass the NCLEX the first try. With our question bank platform, you are able to see the analysis of how ready you are for the NCLEX exam with a detailed analysis based on your performance. So check out our website for all those goodies. And I hope this lecture helped you feel a bit more confident with the pharmacology section, whether you're studying for nursing school or gearing up for the NCLEX. Again, I'm Mark Johnson, your NCLEX instructor here at YNS, and I'll see you in the next lecture. Welcome to part 2 of our NCLEX Pharmacology lecture. If you haven't yet watched the first part, I highly encourage you to go back and start there. In that session, we laid the groundwork, looking at how pharmacology is tested on the NCLEX and how to approach it from a clinical, test-based mindset. That foundation will help you move through this next phase with clarity and confidence. My name is Mark Johnson. I'm an ICU nurse and your NCLEX instructor here at YNS. In today's session, we're diving deeper into pharmacology, breaking it down system by system. We'll begin with cardiovascular medications, specifically antihypertensives, which are not only high yield for the exam, but absolutely essential to safe, effective nursing practice in any setting. And if you want to follow along this lecture with the detailed and visual notes, check out our pharmacology mastery notes on our website, yournursingspace.com. Okay, without further ado, let's dive into the number one pharmacology must-knows, cardiovascular medications. When we talk about blood pressure medications, it's helpful to remember the classic framework, the ABCD of antihypertensives. This stands for ACE inhibitors and ARBs, beta blockers, calcium channel blockers, and diuretics. Each class works differently, affects different systems, and requires different nursing considerations. But they all aim toward the same goal, protecting the heart, the brain, and the kidneys by managing hypertension. Let's begin with the ACE inhibitors and ARBs, which both work within the renin-angiotensin-aldosterone system, one of the most powerful regulators of blood pressure in the human body. ACE inhibitors, easily recognized by the suffix -pril, include medications like lisinopril, enalapril, and captopril. These drugs block the angiotensin-converting enzyme, which is responsible for transforming angiotensin I into angiotensin II, a potent vasoconstrictor. By inhibiting this enzyme, ACE inhibitors reduce vasoconstriction, decrease blood pressure, and ease the workload on the heart. These medications are commonly used not only for hypertension, but also for heart failure and for kidney protection in patients with diabetes. However, ACE inhibitors are known for a few signature side effects. Most notably, they can cause a dry, persistent cough, which is thought to result from increased levels of bradykinin. While not dangerous, the cough can be disruptive enough that patients may ask to stop the medication. More concerning is angioedema, a rare but serious reaction involving rapid swelling of the lips, tongue, or throat. If this occurs, the medication must be stopped immediately. ACE inhibitors also raise potassium levels, so we need to monitor for hyperkalemia, and patients should avoid potassium supplements or salt substitutes unless specifically instructed otherwise. If a patient cannot tolerate an ACE inhibitor, particularly due to the cough, we often switch to an ARB or angiotensin II receptor blocker. These drugs, such as losartan, valsartan, and telmisartan, end in sartan, and work by blocking the receptors that angiotensin II binds to. The effect is the same, lower blood pressure and reduced vascular resistance, but without increasing bradykinin levels. This means no cough and a much lower risk of angioedema, although it's not zero. Like ACE inhibitors, ARBs can also cause hyperkalemia, so potassium levels must still be monitored. With those vasodilatory mechanisms covered, let's move on to beta blockers, a cornerstone of cardiovascular pharmacology, especially in patients with hypertension, arrhythmias, or a history of myocardial infarction. Beta blockers, which end in LOL, include familiar names like metoprolol, atenolol, propranolol, and carvedilol. These medications work by blocking the beta-adrenergic receptors in the heart, primarily beta-1 receptors, thereby reducing the effects of adrenaline. This slows the heart rate, decreases myocardial contractility, and ultimately lowers blood pressure. Some beta blockers like metoprolol and atenolol are cardioselective, meaning they primarily affect the heart and are safer in patients with asthma or COPD. Others, like propranolol and carvedilol, are non-selective and should be avoided in patients with reactive airway diseases because they can cause bronchoconstriction by also blocking beta-2 receptors in the lungs. From a nursing standpoint, beta blockers require careful pre-administration checks. Always assess the heart rate and blood pressure before giving the dose. If the heart rate is below 60 beats per minute or the systolic blood pressure is under 100 millimeters of mercury, the medication should be held and the provider notified. These drugs should never be stopped abruptly, as doing so can cause rebound tachycardia or even hypertensive crisis. For diabetic patients, keep in mind that beta blockers can mask the early signs of hypoglycemia, especially the typical increase in heart rate, so blood glucose monitoring becomes even more important. Next, we move into C, calcium channel blockers. These drugs prevent calcium from entering the muscle cells of the heart and arteries, resulting in decreased contractility and vasodilation. The result is lowered blood pressure and, in some cases, a reduced heart rate. Calcium channel blockers are divided into two groups: the dipine drugs, like amlodipine and nifedipine, which primarily act on blood vessels to cause vasodilation and lower blood pressure, and the non-dihydropyridines, verapamil and diltiazem, which also affect the heart's conduction system and are often used to manage arrhythmias like atrial fibrillation. Nursing considerations for calcium channel blockers include assessing blood pressure before administration. If the systolic pressure is below 100 millimeters of mercury, you'll generally want to hold the dose. Patients should be cautioned not to consume grapefruit juice, as it can inhibit liver enzymes and raise the drug concentration to potentially dangerous levels. Additionally, these medications can cause peripheral edema, as well as dizziness, particularly with the first few doses, due to their vasodilatory effect. Finally, we arrive at D, diuretics, a critical class of medications used to eliminate excess fluid from the body, which in turn reduces blood pressure and the heart's workload. There are several types of diuretics, each with its own clinical use. Loop diuretics, such as furosemide and bumetanide, are very potent and often used in acute settings like pulmonary edema or congestive heart failure. These medications remove large volumes of fluid quickly, but they also strip the body of potassium, leading to hypokalemia. Nurses must monitor electrolyte levels carefully and often administer potassium supplements concurrently. Thiazide diuretics, such as hydrochlorothiazide and chlorthalidone, are frequently used for long-term blood pressure control. They are less potent than loop diuretics but can still cause hypokalemia, as well as mild increases in blood sugar, uric acid, and lipid levels. On the other hand, potassium-sparing diuretics, like spironolactone and eplerenone, help the body retain potassium while promoting fluid excretion. These are often used in patients with heart failure or those at risk for low potassium levels. However, they carry the risk of hyperkalemia, especially when combined with ACE inhibitors or ARBs. As a rule of thumb, all diuretics should be given in the morning to prevent frequent nighttime urination. Nurses must monitor intake and output, daily weights, electrolytes, and renal function regularly to prevent complications. So to summarize where we are so far, ACE inhibitors and ARBs help regulate blood pressure by targeting the RHRS system. Beta blockers reduce cardiac workload by slowing the heart. Calcium channel blockers promote vasodilation and, in some cases, slow the heart rhythm. And diuretics eliminate excess fluid to reduce both blood pressure and cardiac strain. This ABCD approach gives us a comprehensive foundation for managing hypertension and many cardiovascular conditions. Now that we've covered the ABCDs of antihypertensives, we're going to continue our cardiovascular pharmacology discussion. Let's begin with vasodilators. These medications function by directly dilating the arteries, which leads to a rapid reduction in blood pressure. Because they decrease afterload, the pressure the heart must work against to eject blood, they are particularly beneficial in managing conditions like heart failure, where the heart is already struggling to pump effectively. Among the commonly used vasodilators is nitroglycerin, which is primarily used to manage acute chest pain or angina, and is also helpful in cases of congestive heart failure. It's important for patients using nitroglycerin to be instructed on proper storage, as it must be kept in a dark glass bottle to preserve its potency. Additionally, in an episode of chest pain, the patient may take one dose every 5 minutes up to a total of 3 doses. If the pain persists after the 3rd dose, it is considered a medical emergency and requires immediate intervention. Another vasodilator, hydralazine, is used for managing hypertension and heart failure and is notable for being safe during pregnancy, especially in cases of pregnancy-induced hypertension. In contrast, sodium nitroprusside is a potent agent reserved for hypertensive emergencies. It is administered intravenously and requires careful monitoring due to the potential for cyanide toxicity. This rare but serious complication can present as confusion or signs of metabolic acidosis, necessitating close observation and prompt discontinuation if toxicity is suspected. Common side effects associated with vasodilators include hypotension due to the sudden drop in vascular resistance, reflex tachycardia as the body attempts to compensate for lowered blood pressure, and symptoms such as dizziness, headache, and fluid retention leading to edema. From a nursing perspective, it is essential to monitor the patient's blood pressure very closely. In situations where reflex tachycardia develops, a beta blocker may be prescribed to help control the heart rate and mitigate the compensatory mechanism. These drugs work quickly and are often used in emergency settings where rapid blood pressure control is necessary, but their potency also demands heightened clinical vigilance. Moving on to antiarrhythmic medications, these drugs are used to regulate abnormal heart rhythms, especially those that may be life-threatening. One of the most important agents in this class is amiodarone, which is indicated for serious arrhythmias such as ventricular fibrillation and ventricular tachycardia. Amiodarone exerts its effects by blocking potassium channels, which prolongs the repolarization phase of the cardiac action potential. This delay slows the heart rate and stabilizes cardiac rhythm. However, while effective, amiodarone carries several serious adverse effects. One major concern is pulmonary toxicity, which may present as a new onset of cough or shortness of breath. If these symptoms arise, the drug should be stopped immediately, and the patient should be assessed for pulmonary complications. Additionally, amiodarone can cause liver toxicity, so regular monitoring of liver function tests is warranted. It may also lead to visual disturbances such as corneal deposits and thyroid dysfunction, which can manifest as either hypothyroidism or hyperthyroidism. Other antiarrhythmics include lidocaine, administered intravenously to manage ventricular arrhythmias, and adenosine, which is used to treat supraventricular tachycardia by temporarily slowing the heart rate. These drugs are typically administered in acute care settings under continuous monitoring due to their potent effects on cardiac rhythm. For more information about detailed cardiovascular medications such as antiplatelets, anticoagulants, and digoxin, check out our website for the full notes. Now let's shift gear to respiratory medications. The primary goal is to open the airways, reduce inflammation, and ultimately improve oxygenation. These drugs are essential in managing conditions like asthma, COPD, emphysema, and chronic bronchitis. Since airway obstruction is a hallmark of these diseases, the first step in treatment is almost always to restore airflow, and this is where bronchodilators come in. Bronchodilators are the frontline treatment in both asthma and COPD. Among them, short-acting beta-2 agonists, or SABAs, are especially important because they provide rapid relief. These medications act on beta-2 receptors in the lungs, relaxing bronchial smooth muscle and opening up the airways almost immediately. Albuterol is the most commonly used SABA, and it is the first medication we reach for during an acute asthma attack. That's a critical NCLEX concept. If a patient is in distress, albuterol is the first-line rescue. Levobuterol works similarly but is sometimes preferred in patients who experience too much tachycardia or jitteriness from albuterol. These medications have an onset of action between 5 to 15 minutes, and their side effects include tachycardia, palpitations, tremors, and occasionally hypokalemia. Restlessness and shakiness are also common and expected. Because of these side effects, it's essential to monitor the patient's heart rate and potassium levels if used frequently. Despite their strong therapeutic benefit, SABAs are not meant for long-term control. They are quick relief or rescue inhalers only. For long-term maintenance, we turn to long-acting beta-2 agonists, or LABAs, such as salmeterol and formoterol. These drugs are used to maintain open airways over time, especially in patients with moderate to severe asthma or COPD. However, there's an important NCLEX safety point to remember. LABAs should never be used alone in asthma treatment. Doing so increases the risk of asthma-related death. They must always be prescribed in combination with an inhaled corticosteroid. The reasoning behind this is that while LABAs open the airways, they do not address the underlying inflammation. Without an anti-inflammatory component, the airway remains vulnerable. Their side effect profile is similar to SABAs, including tachycardia, tremors, and palpitations. But because they are used daily, monitoring is less urgent unless symptoms worsen. Another category of bronchodilators includes anticholinergic medications, easily identified by the tropium suffix. These drugs work by blocking the parasympathetic nervous system, which normally causes bronchoconstriction and stimulates mucus secretion. By blocking this response, anticholinergics relax the airways and reduce secretions. These are particularly beneficial in COPD management and are used for maintenance rather than rescue. Ipratropium is a short-acting anticholinergic often used alongside albuterol, while tiotropium is long-acting and taken once daily for ongoing COPD management. However, it's essential to remember that anticholinergics are not to be used in acute respiratory distress. They take time to work. One of the most common side effects of this class is dry mouth. Patients can manage this by sipping water or chewing sugar-free gum. Other side effects include blurry vision, constipation, and urinary retention. Because of these effects, anticholinergics are contraindicated in patients with narrow-angle glaucoma and benign prostatic hyperplasia. This is important to assess before initiating therapy. Now, while bronchodilators open the airways, they do not address inflammation, which is a central feature in asthma. For that, we use corticosteroids. These drugs come in two forms: inhaled and systemic. Inhaled corticosteroids, or ICS, are used daily for long-term control in both asthma and COPD. Common examples include fluticasone and budesonide. These drugs reduce airway inflammation and prevent exacerbations by decreasing swelling and mucus production in the bronchi. There are a couple of key administration principles that are testable on the NCLEX. First, if a patient is using both a bronchodilator and an inhaled corticosteroid, the bronchodilator should be used first. This opens up the airways and allows the steroid to reach deeper into the lungs. After using an ICS, the patient should rinse their mouth thoroughly to prevent oral candidiasis, also known as thrush. This fungal infection is a common side effect due to the localized immune suppression from the steroid. Systemic corticosteroids, such as prednisone, taken orally, and methylprednisolone, given intravenously, are used for severe asthma attacks or acute exacerbations of COPD. These are powerful anti-inflammatory agents, but come with a significant side effect profile, especially when used long-term. Patients may experience hyperglycemia, increased risk of infection, osteoporosis, mood changes including depression, fluid retention, and weight gain. These can be remembered with the 6 S's: sugar, high glucose; soft bones, osteoporosis; sick, immunosuppression; SAD, mood changes; salt, fluid retention; and swollen, weight gain. It's also important to taper these medications slowly after prolonged use to avoid adrenal insufficiency, which can be life-threatening. Next, we have the leukotriene modifiers, such as montelukast, zafirlukast, and xoluton. These medications block the action of leukotrienes, chemical mediators that cause inflammation, bronchoconstriction, and mucus production. Montelukast, in particular, is widely used for asthma prevention and allergic rhinitis. It's taken orally and is particularly helpful in patients who have asthma triggered by allergens or exercise. This drug is taken in the evening, as absorption and symptom control are generally better at that time. An important NCLEX point is that montelukast is not for acute asthma attacks. It is used strictly for prevention. Patients should also be monitored for changes in mood, including depression and suicidal ideation, which have been reported in some individuals. While rare, this is serious and warrants immediate attention if symptoms arise. When mucus production becomes problematic, especially in chronic bronchitis or cystic fibrosis, mucolytics and expectorants are used to assist with clearance. Acetylcysteine, commonly known as Mucomyst, is a mucolytic that breaks down the structure of thick mucus, making it easier to cough up. Interestingly, it is also the antidote for acetaminophen toxicity. Patients should be warned that it has a strong sulfur odor, often described as smelling like rotten eggs, which can be off-putting. Guaifenesin is an expectorant that helps thin mucus, making coughs more productive. Adequate hydration is essential when using expectorants, as water is needed to effectively thin the mucus. Both mucolytics and expectorants can cause gastrointestinal upset, so they are best taken with food. In cases of a dry, non-productive cough, antitussives are used. These medications suppress the cough reflex and are generally reserved for nighttime use or situations where coughing interferes with rest. Dextromethorphan is a commonly used, non-opioid antitussive found in many over-the-counter formulations. In high doses, it can cause hallucinations, which is why it is sometimes misused recreationally. Codeine, on the other hand, is an opioid antitussive used for more severe cough. Because of its sedating properties and potential for respiratory depression, it must be used with caution. Antitussives should never be used in cases of productive cough, as suppressing the cough can trap mucus in the lungs and lead to complications like infection. This layered approach, relieving bronchospasm, reducing inflammation, and supporting airway clearance, is the foundation of respiratory pharmacology and critical knowledge for NCLEX success. Let's now move into another cornerstone of pharmacology, corticosteroids. These medications are incredibly powerful and versatile. You'll encounter them often in respiratory, dermatologic, autoimmune, and endocrine conditions. Because they mimic cortisol, the body's natural steroid hormone produced by the adrenal cortex, corticosteroids influence everything from metabolism to fluid balance, immune response, and stress adaptation. Corticosteroids are easy to spot because most of them end in "sone" or "id", for example, prednisone, methylprednisolone, fluticasone, and budesonide. We'll begin by breaking them down by route and purpose so you understand how they're used in clinical settings. First, we have inhaled corticosteroids, also called ICS. These are commonly prescribed for daily maintenance in asthma and COPD, helping to prevent airway inflammation and mucus production over time. Key examples include fluticasone, Flovent, and budesonide, Pulmicort. These drugs are not meant to treat acute attacks, but are essential for long-term control. In fact, inhaled corticosteroids are considered first-line therapy for persistent asthma. Nursing guidance here is crucial. If the patient is using both a bronchodilator, like albuterol, and an ICS, they must use the bronchodilator first. Wait about 5 minutes, and then use the steroid inhaler. This allows the airways to open up so the steroid can penetrate more effectively. Also, patients should be instructed to rinse the mouth after inhalation to prevent oral thrush, a common complication due to localized immune suppression in the mouth. Second, let's look at oral and intravenous corticosteroids. These systemic steroids are reserved for more severe asthma exacerbations, COPD flares, autoimmune conditions, and inflammatory diseases. Common examples include prednisone, which is oral, and methylprednisolone, which is IV. Because they enter systemic circulation, they carry a much higher risk of widespread side effects, which we'll discuss shortly. Third, we have nasal corticosteroids, used primarily for seasonal allergies, nasal congestion, and sinus inflammation. Examples include fluticasone, budesonide, mometasone, and triamcinolone. These medications should be used daily for best results and typically take 1 to 2 weeks to reach full effectiveness. Patients should blow their nose before use, spray away from the nasal septum, and avoid blowing the nose immediately afterward to allow for absorption and minimize irritation or nosebleeds. Fourth, we have topical corticosteroids, often used for skin conditions like eczema, psoriasis, and allergic rashes. These come in various potencies. For example, hydrocortisone is a low-potency, over-the-counter cream, while triamcinolone is medium strength and clobetasol or betamethasone are high-potency prescription options. These should always be applied in thin layers, never used on open wounds, and avoided on the face or sensitive areas unless prescribed for short-term use, due to the risk of skin thinning and delayed wound healing. Now let's talk about what happens with long-term use, especially with systemic corticosteroids. This is heavily tested on the NCLEX because of the wide-ranging effects on nearly every organ system. You can remember these complications using the acronym STEROID, S. Sugar increase. Corticosteroids raise blood glucose levels by increasing gluconeogenesis, putting patients at risk for hyperglycemia or even diabetes. T. Truncal obesity. Long-term use leads to fat redistribution, causing features like moon face, buffalo hump, and central weight gain. E. Electrolyte imbalances, specifically hypokalemia and fluid retention, contributing to hypertension. R. Risk for infection. These drugs suppress the immune system, making even minor infections potentially dangerous. O. Osteoporosis. Steroids impair calcium absorption and decrease bone formation, leading to bone thinning and fracture risk. I. Insomnia and irritability. Patients often report mood swings, anxiety, and trouble sleeping. D. Delayed wound healing. Corticosteroids slow down collagen synthesis and can lead to easy bruising and poor tissue repair. There are several universal nursing responsibilities when managing patients on any type of corticosteroid, especially systemic ones. Always monitor blood glucose levels, especially in diabetics or anyone on long-term therapy. Educate patients to take corticosteroids with food to reduce gastrointestinal irritation and prevent ulcers. Keep a close eye on signs of infection, remembering that fevers may be absent due to immune suppression. Instruct patients to never stop corticosteroids abruptly after prolonged use. They must be tapered gradually under provider supervision. For long-term users, monitor for signs of osteoporosis and consider calcium and vitamin D supplementation if appropriate. One of the most critical concepts on the NCLEX regarding corticosteroids is adrenal suppression and the potential for adrenal crisis. This occurs when a patient who's been on long-term corticosteroids stops suddenly. The adrenal glands, which have been suppressed during steroid therapy, cannot produce cortisol fast enough to meet the body's needs. Symptoms of adrenal crisis include severe hypotension, fatigue, weakness, shock, low blood sugar, and high potassium levels. This is a medical emergency and must be treated immediately with IV hydrocortisone, Solu-Cortef, and IV fluids to restore perfusion and cortisol levels. Finally, let's briefly compare Addison's disease and Cushing's syndrome, focusing only on what's pharmacologically relevant. In Addison's disease, the adrenal glands don't produce enough cortisol. The treatment? We ADD steroids, specifically hydrocortisone and fludrocortisone, and patients will often need to increase the dose during times of stress to avoid crisis. In Cushing's syndrome, the body has too much cortisol, usually due to long-term steroid therapy or endogenous overproduction. The solution here is usually to taper off the corticosteroids under supervision and manage the complications of excess cortisol. So the takeaway is this: low cortisol? Think Addison's. Add steroids. High cortisol? Think Cushing's. Cut back steroids. Now let's talk about a high-risk, high-reward group of medications: anticoagulants and antiplatelets. These drugs are used to prevent clots in conditions like stroke, DVT, pulmonary embolism, and atrial fibrillation. While they don't break down existing clots, they help stop clots from forming or getting bigger. The difference between the two is important. Antiplatelets prevent platelets from clumping together. They're used mostly to prevent arterial clots, like in heart attacks or strokes. Anticoagulants work deeper in the clotting process by slowing down clotting factors in the blood. They're used to prevent venous clots, like in DVTs, PEs, or AFib. Let's start with anticoagulants. Heparin is a fast-acting anticoagulant given intravenously or subcutaneously. It requires close monitoring of activated partial thromboplastin time levels, which should be 1.5 to 2 times the normal value, around 45 to 80 seconds. The antidote for heparin is protamine sulfate. A serious complication is heparin-induced thrombocytopenia, a dangerous drop in platelets with increased clotting risk. Enoxaparin is a low molecular weight heparin given subcutaneously. It has a more stable effect and doesn't need a PTT monitoring. It also shares the same antidote, protamine sulfate. Warfarin is a slow-acting oral anticoagulant. It's monitored using the INR, which should stay between 2 and 3. The antidote is vitamin K. and patients should eat a consistent amount of leafy greens to avoid sudden changes in vitamin K levels. Also, antibiotics can increase INR, making bleeding more likely. Now let's look at antiplatelets. Aspirin irreversibly blocks platelets for 7 to 10 days, so it's held a week before surgery. It's used for heart attack and stroke prevention, but it can cause GI bleeding and tinnitus, which is an early sign of toxicity. Clopidogrel also prevents platelet clumping and is commonly given after stent placement or for stroke prevention. Side effects include bleeding and bruising, so patients should report any signs like bloody gums, petechiae, or dark stools. Now let's quickly touch on thrombolytics, which are the only drugs that dissolve clots. They're used in emergencies only, such as ischemic stroke, massive PE, or heart attack. Alteplase TPA is the most common. It must be given within 3 to 4.5 hours of stroke symptoms. These drugs come with a high risk of bleeding, especially intracranial hemorrhage. That's why they are not given to anyone with active bleeding, recent surgery, or a history of hemorrhagic stroke. Whether your patient is on an anticoagulant, an antiplatelet, or a thrombolytic, always watch for signs of bleeding, such as petechiae, bruising, ecchymosis, blood in urine, hematuria, black tarry stools, melena, nosebleeds or bleeding gums. If bleeding happens, stop the drug, give the antidote if available, and monitor vitals closely. A drop in blood pressure could mean internal bleeding. So to sum up, anticoagulants like heparin and warfarin prevent venous clots. Antiplatelets like aspirin and Plavix prevent arterial clots. Thrombolytics like TPA break down clots in emergencies. Pain is one of the most important and complex sensations we assess in nursing. It is not just a physical response, but a subjective, personal experience influenced by biological, psychological, and emotional factors. Understanding the different types of pain is essential for selecting the most appropriate treatment. We classify pain by duration, source, and mechanism. Acute pain comes on suddenly and is usually associated with a specific injury, surgical procedure, or illness. It tends to resolve as the underlying cause heals. In contrast, chronic pain persists for longer than 3 to 6 months and may be either constant, as in arthritis, or intermittent, like migraines. Neuropathic pain is caused by nerve damage and is typically described as burning, tingling, or shooting, seen in conditions like diabetic neuropathy or phantom limb pain. On the other hand, nociceptive pain is related to tissue damage and can be somatic, from skin, bones, muscles, or visceral, from internal organs. Patients often describe this type of pain as sharp, throbbing, or aching. Lastly, referred pain occurs when the sensation is felt in a different location from its origin, such as left arm pain during a heart attack. A thorough pain assessment helps determine the type, severity, and appropriate treatment. Nurses often use the PQRST method, P for provocation or palliation, what makes it better or worse, Q for quality, how the pain feels, R for region and radiation, where the pain is and whether it spreads, S for severity, using tools like the numeric rating scale or Wong-Baker faces, and T for timing, when it started, how long it lasts, whether it's constant or intermittent. For infants and nonverbal patients, we use the FLACC scale, which assesses facial expression, leg movement, activity, crying, and consolability. Non-pharmacologic pain management can be very effective, especially when used in combination with medications. These approaches include cognitive behavioral techniques such as distraction and guided imagery, physical therapies like heat or cold applications, massage, acupuncture, and positioning to reduce discomfort. Interventions like music therapy and relaxation exercises are also valuable, particularly for patients with chronic or procedural pain. When it comes to medications, the first category we consider is opioids, which are reserved for moderate to severe pain. These medications work by binding to opioid receptors in the brain and spinal cord, blocking the perception of pain. Morphine is the gold standard, used in many settings through IV, oral, or patient-controlled analgesia, PCA. Fentanyl is a much stronger opioid, about 100 times more potent than morphine, and comes in patches, lozenges, and IV forms. Hydromorphone is another strong opioid, often used in surgical or cancer pain. Oxycodone is commonly prescribed after surgery and often combined with acetaminophen. Codeine is a weaker opioid used in some cough syrups and for mild pain. Tramadol is a synthetic opioid used for moderate pain and has a lower abuse potential, while methadone and buprenorphine are used not only for chronic pain, but also for treating opioid use disorder. Because of their powerful effects, opioids carry serious risks. The most critical is respiratory depression, which can occur even at therapeutic doses, especially in opioid-naive patients. If a patient's respiratory rate drops below 12 per minute, the opioid should be held. Overdose symptoms include pinpoint pupils, unconsciousness, and slow breathing, a classic triad of opioid toxicity. In these cases, naloxone, Narcan, is the antidote and can be administered intranasally, IM, or IV, to rapidly reverse the effects. Additionally, patients on opioids often experience constipation due to slowed GI motility, so stool softeners or laxatives should be routinely prescribed. Nurses should educate patients to avoid alcohol, benzodiazepines, or any other CNS depressants while taking opioids due to the compounded risk of sedation and respiratory failure. For mild to moderate pain, we typically use non-opioid medications like NSAIDs and acetaminophen. NSAIDs, non-steroidal anti-inflammatory drugs, are particularly effective for pain associated with inflammation. Ibuprofen and naproxen are common over-the-counter options, while ketorolac is a potent NSAID often used after surgery, but limited to 5 days due to its GI and renal toxicity. Aspirin not only relieves pain but also prevents clot formation when given in low doses daily. Celecoxib, a KOX2 selective NSAID, provides similar pain relief with a reduced risk of GI irritation, making it a better option for long-term use. Despite their usefulness, NSAIDs come with significant risks. They can cause gastric ulcers and GI bleeding, especially in older adults or when taken without food. They may also impair renal function, particularly in patients with pre-existing kidney disease. So kidney function tests, BUN, creatinine, must be monitored. NSAID are also contraindicated in pregnancy, especially in the third trimester, due to the risk of premature ductus arteriosus closure in the fetus and increased bleeding risk in the mother. Patients should stop taking NSAID before surgery to reduce the risk of intraoperative bleeding. Acetaminophen, Tylenol, is often considered the gentler pain reliever, but it also has serious risks when used improperly. It does not reduce inflammation, but it is effective for fever and mild pain and is generally safer for the stomach and kidneys. It's commonly found in combination drugs like Percocet or Vicodin, paired with opioids for more comprehensive pain relief. However, it can be toxic to the liver in high doses. The maximum recommended dose is 4 grams per day, or 3 grams per day in patients with liver disease. Overdose can result in acute liver failure, and the antidote is acetylcysteine, which works by replenishing liver protective compounds. A key NCLEX tip here: combining alcohol with acetaminophen significantly increases the risk of fatal liver damage. For specialized types of pain, particularly neuropathic or chronic pain, we use adjuvant analgesics. These are not primary pain medications but are used to enhance pain relief in specific conditions. For example, gabapentin and pregabalin are anticonvulsants commonly prescribed for nerve pain and fibromyalgia. They work by calming overactive nerve signaling. Antidepressants like amitriptyline, duloxetine, and venlafaxine are used for chronic pain, particularly in diabetic neuropathy and fibromyalgia, and they modulate neurotransmitters involved in pain perception. Muscle relaxants, including baclofen and cyclobenzaprine, help relieve pain from muscle tension or spasticity. Finally, corticosteroids such as prednisone and dexamethasone are often used for inflammatory pain related to cancer, arthritis, or autoimmune diseases. While effective, these medications carry risks of drowsiness, mood changes, and metabolic side effects. For antidepressants in particular, gradual tapering is essential to avoid withdrawal symptoms like irritability, dizziness, or flu-like discomfort. In procedural and surgical settings, we rely on local and general anesthetics. Local anesthetics, like lidocaine, are used to numb a specific area, either topically or through injection. Patches and creams like EMLA are commonly used before needle procedures or minor skin interventions. Bupivacaine and ropivacaine are longer-acting agents often used in epidurals or nerve blocks. General anesthetics, such as propofol, ketamine, and nitrous oxide, induce unconsciousness for surgeries or procedures. Propofol, known for its fast onset and offset, requires careful monitoring due to risks of hypotension and respiratory depression. Ketamine, which provides dissociative anesthesia, is unique in that it preserves airway reflexes and can also be used in chronic pain management. Nitrous oxide, commonly used in dental procedures, provides light sedation and pain relief with minimal systemic effects. Throughout all categories of pain medications, nursing responsibilities are critical in preventing complications. Nurses must be able to recognize life-threatening adverse effects, especially with opioids. The classic signs of opioid overdose, slow breathing, pinpoint pupils, and unconsciousness require immediate action with naloxone. With NSAIDs, the biggest concerns are GI bleeding and renal impairment. And with acetaminophen, liver toxicity is the primary danger, particularly when combined with alcohol. Understanding these risks and educating patients on safe medication practices is a key nursing role and a frequent NCLEX test point. In summary, pain management is not one-size-fits-all. It requires accurate assessment, knowledge of medication mechanisms, careful monitoring, and thoughtful patient education. Whether using non-opioids, opioids, adjuvants, or anesthetics, the nurse's role in ensuring safe, effective pain control is central to both healing and... Okay, based on today's lecture, let's practice some NCLEX-type questions. Question 1. A client recently started on lisinopril for heart failure and calls the clinic complaining of a persistent dry cough. What is the nurse's best response? The correct answer is, we'll notify your provider. You may be switched to another medication. Rationale. A dry, persistent cough is a well-known side effect of ACE inhibitors like lisinopril. It's caused by increased levels of bradykinin and is not dangerous, but it can be bothersome enough that the provider might choose to switch the patient to an ARB, like losartan. It's not a reason to rush to the emergency room unless there are signs of angioedema, and telling the client to just continue taking it is not appropriate without discussing it with the provider. Question 2. The nurse is reviewing lab results for a client on long-term methylprednisolone therapy. Which finding is most expected? The correct answer is elevated blood glucose and low potassium. Rationale. Systemic corticosteroids, especially when used long-term, commonly cause hyperglycemia by increasing gluconeogenesis, and they may lead to hypokalemia due to fluid shifts and renal effects. These are expected findings. While corticosteroids also affect the immune system, white blood cell counts are typically elevated, not decreased due to demargination, and low blood glucose would be unexpected in this context. Question 3. A client receiving intravenous heparin suddenly develops a platelet count of 90,000 and complains of leg pain. What is the nurse's priority action? The correct answer is notify the provider immediately. Rationale. A sudden drop in platelet count combined with signs of new clot formation, like leg pain, suggests heparin-induced thrombocytopenia, AHIT. This is a serious complication that increases the risk for thrombotic events. The priority is to stop the heparin and notify the provider so the patient can be evaluated and switch to a non-heparin anticoagulant. Protamine sulfate is used for active bleeding, not for HUD, and vitamin K is used for warfarin, not heparin. Question 4. A client prescribed ipratropium reports a dry mouth. What is the nurse's most appropriate response? The correct answer is, this is a common side effect. Try chewing sugar-free gum or sipping water. Rationale: ipratropium is an anticholinergic bronchodilator, and dry mouth is one of its most common side effects. This is not an allergic reaction, and it doesn't require stopping the medication. Instead, we manage it with comfort measures like sugar-free gum or frequent sips of water. Rinsing the mouth is essential for inhaled corticosteroids, not anticholinergics, and grapefruit juice has no role here. Question 5. A nurse is preparing to administer IV ketorolac to a post-op patient. What is the most appropriate action before giving the drug? The correct answer is, assess the client's kidney function before administration. Rationale: ketorolac is a potent NSAID that can be nephrotoxic, especially if used for longer than 5 days. Before administering, the nurse should check the client's kidney function, including BUN and creatinine levels. The drug should always be taken with food or fluids to minimize gastrointestinal side effects. While it may sometimes be combined with opioids, that's a provider decision, not a nursing priority, and continuing it beyond 5 days is unsafe. All right, that wraps up part 2 of our Pharmacology NCLEX lecture series. If this helped you out, don't forget to subscribe, like, and hit the notification bell so you don't miss part 3 and all the other good stuff coming your way. And if you're looking for the detailed pharmacology guide notes from this lecture, head over to our website, yournursingspace.com. You'll find in-depth lecture notes, NCLEX-specific resources, and more tools to help you pass with confidence. You can also check out our test bank platform, Exam ASAP, our advanced adaptive testing platform featuring over 5,000 peer-reviewed questions designed to mirror the NCLEX experience. It includes detailed rationales, daily content updates, and a 24/7 AI tutor, resources recognized as industry-leading and proven to enhance your performance. Not only that, our question bank platform has next-generation NCLEX question types with case studies. We are adaptive and AI-powered platform that allows you to pass the NCLEX the first try. With our question bank platform, you are able to see the analysis of how ready you are for the NCLEX exam with a detailed analysis based on your performance. So check out our website for all those goodies. And I hope this lecture helped you feel a bit more confident with the pharmacology section, whether you're studying for nursing school or gearing up for the NCLEX. Again, I'm Mark Johnson, your NCLEX instructor here at YNS, and I'll see you in the next lecture. Welcome to part 3 of our NCLEX Pharmacology lecture series. If you haven't had the chance to watch parts 1 and 2 yet, I highly recommend starting there first. Those lessons lay the groundwork with key concepts that will make today's material much easier to follow. My name is Mark Johnson. I'm an ICU nurse and your NCLEX instructor here at YNS. In this lecture, we're diving deeper into pharmacology, this time breaking it down by body systems so it's easier to understand and apply. Today, we're starting with a big one, endocrine system medications. And if you want to follow along this lecture with the detailed and visual notes, check out our pharmacology mastery notes on our website, yournursingspace.com. Without further ado, let's start with endocrine medications. The endocrine system controls some of the body's most essential functions, including blood sugar regulation, metabolism, fluid balance, growth, and reproductive health. So naturally, medications in this system target conditions like diabetes, thyroid disorders, adrenal dysfunction, and pituitary imbalances. Let's break this down system by system, starting with thyroid medications. We'll begin with hypothyroidism. That's low T3 and T4 and high TSH. The medication of choice is levothyroxine, a synthetic T4 that the body converts to T3. It's used for both hypothyroidism and myxedema coma. Key points. Take it in the morning on an empty stomach, at least 30 to 60 minutes before food. Avoid calcium, iron, or antacids which reduce absorption. It takes several weeks to see full effects, and TSH is monitored to adjust dosage. This is lifelong therapy, so don't stop it abruptly. If the dose is too high, look for signs of hyperthyroidism, tachycardia, insomnia, weight loss, heat intolerance. Think levo. Lifelong empty stomach. Very active if overdosed. Other meds interfere. On the other hand, hyperthyroidism means high T3 and T4 and low TSH. It's treated with methimazole or propylthuracil, PTU. These drugs block thyroid hormone production and are used in Graves' disease or thyroid storm. PTU is used in pregnancy, while methimazole is generally preferred otherwise. Watch for agranulocytosis. Signs include fever and sore throat, and hepatotoxicity. Also, monitor for signs of hypothyroidism if the dose is too strong. Take with food to avoid GI upset and avoid iron or antacids. Remember, PTU puts the thyroid underground. It suppresses thyroid hormone levels. Let's shift to blood sugar management, starting with hypoglycemia, low blood sugar. It shows up with signs like sweating, cold and clammy skin, shakiness, confusion, and irritability. If the patient is conscious, we follow the rule of 15. Give 15 grams of a fast-acting carbohydrate, juice, glucose tabs, or honey, then recheck blood sugar in 15 minutes. If it's still low, repeat. Once stable, follow up with a complex carb and protein combo, like peanut butter and crackers, to maintain blood sugar. If the patient is unconscious, the first choice in the hospital is IVD 50, dextrose 50%. At home, we give IM glucagon. Since glucagon can cause vomiting, turn the patient on their side to prevent aspiration. Now let's look at hyperglycemia, which you'll recognize with the 3 Ps: polyuria, polydipsia, and polyphagia, plus signs like hot, dry skin, blurred vision, fatigue, and in more severe cases, fruity breath and Kussmaul's respirations. These are hallmark signs of diabetic ketoacidosis, DKA. Treatment for hyperglycemia includes administering insulin, especially intravenous insulin, for diabetic ketoacidosis, while monitoring potassium closely, since insulin drives potassium into cells. We also encourage hydration, monitor blood glucose levels frequently, and assess for urinary ketones. Long-term management includes educating patients about carbohydrate consistency and medication adherence. A good way to remember: cold and clammy, need some candy for hypoglycemia. Hot and dry, sugar's high for hyperglycemia. Now let's get into insulin. For the NCLEX, you need to know the onset, peak, and duration of the main types. Rapid-acting insulins like Lispro and Aspart kick in fast, about 15 minutes, and peak around 1 hour. They should be given right at mealtime to avoid hypoglycemia. Short-acting insulin, like regular insulin, has a slower onset and a peak around 2 to 4 hours. Intermediate-acting, such as NPH, takes a few hours to start and peaks around 6 to 12 hours. And long-acting insulins like Glargine or Detamir have no real peak and last over 24 hours. Always draw up regular, clear insulin before NPH, cloudy if you're mixing. And remember, long-acting insulins should never be mixed with other types. Rotate injection sites and always monitor for hypoglycemia, especially during peak times. For type 2 diabetes, the first-line oral med is metformin. It works by reducing glucose production in the liver and making the body more sensitive to insulin. It's usually well tolerated, but we hold it before contrast dye procedures because of the risk for lactic acidosis. We also monitor kidney function, and if the creatinine is above 1.3, we stop the med. It should be taken with food to reduce stomach upset. Sulfonylurias like glipizide and glyburide help the pancreas release more insulin, but they carry a higher risk of hypoglycemia, especially if a patient skips meals. They can also cause weight gain, and alcohol should be avoided because it can trigger severe hypoglycemia. Then we have DPP-4 inhibitors like sitagliptin. These are gentler and often used in older adults, but they come with a risk of pancreatitis, so any report of severe abdominal pain should be taken seriously. For diabetes insipidus, we use desmopressin or DDAVP, which is a synthetic ADH. It helps the kidneys retain water, so we know it's working when urine output decreases. But too much can cause water intoxication, leading to hyponatremia and confusion, so we keep a close eye on sodium levels. For growth hormone deficiency, we use somatropin, which helps stimulate growth but can raise blood sugar, so we monitor for hyperglycemia during treatment. And finally, for osteoporosis, we have bisphosphonates like alendronate. These drugs help prevent bone breakdown and increase bone density, but they need to be taken first thing in the morning on an empty stomach with a full glass of water, and the patient must stay upright for at least 30 minutes after taking it to avoid esophageal irritation. We also monitor calcium and vitamin D levels during therapy to make sure the bones are getting what they need. When it comes to gastrointestinal medications, we focus on managing a range of conditions, everything from acid reflux and ulcers to nausea, constipation, and diarrhea. These are some of the most frequently encountered issues in clinical practice, and understanding how each class of medication works, along with its side effects and nursing implications, is key to safe and effective patient care. Let's start with acid reducers, which are used to manage conditions like GERD, peptic ulcers, gastritis, and heartburn. There are three main categories of acid-reducing drugs: proton pump inhibitors, PPIs, H2 receptor blockers, and antacids, each with its own level of potency and use case. Proton pump inhibitors, easily recognized by the prozole suffix, are the most potent acid reducers. These include medications like omeprazole, pantoprazole, esomeprazole, and lansoprazole. They work by irreversibly blocking the proton pumps in the stomach lining, which are responsible for producing hydrochloric acid. Because these pumps are the final step in acid secretion, PPIs are extremely effective, making them first-line treatment for severe GERD, erosive esophagitis, and ulcer prevention, especially in patients taking NSAIDs. However, this potency comes with risks. PPIs must be taken on an empty stomach, typically in the morning, because food can reduce their absorption. Long-term use is associated with decreased calcium absorption, which increases the risk of osteoporosis and fractures. Additionally, by lowering stomach acid levels, these drugs may increase the risk of C. difficile infection, since acid normally helps kill ingested bacteria. H2 receptor blockers, such as famotidine, ranitidine, withdrawn due to safety concerns, and cimetidine, are milder acid reducers. They work by blocking histamine receptors in the stomach lining, which suppresses acid secretion. Although not as strong as PP is, H2 blockers are often safer for long-term use and are still widely used for less severe GERD or ulcer prevention. They can be taken with food, which makes them convenient, and they are less likely to impair kidney function than PPIs. However, cimetidine should generally be avoided in the elderly due to its risk of confusion, gynecomastia, and drug interactions. Antacids such as magnesium hydroxide, milk of magnesia, calcium carbonate, TUMS, aluminum hydroxide, and sodium bicarbonate act differently. Instead of blocking acid production, they work by neutralizing existing stomach acid, increasing the pH, and providing quick relief from heartburn or indigestion. These are the fastest acting but also the least potent and are generally used for short-term symptom relief. It's important to administer antacids 1 to 3 hours after meals and at bedtime, and to avoid giving them simultaneously with other medications as they may interfere with absorption. Also, keep in mind that magnesium-based antacids can cause diarrhea, while aluminum-based antacids can cause constipation. So sometimes a combination product is used to balance these effects. Now moving on to laxatives, which are used to relieve constipation, a common side effect of many medications, including opioids and a frequent concern in postoperative care. There are 4 main types: bulk-forming, stimulant, osmotic, and stool softeners. Bulk-forming laxatives, such as psyllium and methylcellulose, are considered the safest long-term option. They mimic natural dietary fiber, absorbing water and expanding in the intestines to form a soft, bulky stool that is easier to pass. These medications are not fast-acting and must be taken with plenty of water to prevent intestinal obstruction. Stimulant laxatives, including bisacodyl and senna, are the fastest-acting but also the most aggressive. They directly stimulate the nerves in the intestinal wall, causing contraction and rapid evacuation. While effective for short-term relief, these should not be used daily, as long-term use can lead to dependence and electrolyte imbalances and may damage the enteric nervous system. Osmotic laxatives like milk of magnesia, lactulose, polyethylene glycol, Miralax, and magnesium citrate work by drawing water into the intestines, which softens stool and promotes peristalsis. These can be very effective but may cause dehydration and electrolyte disturbances, especially in older adults or those with renal issues. One important point: lactulose is not only a laxative, but also used in patients with liver disease, especially cirrhosis, because it reduces serum ammonia levels by promoting ammonia excretion through the stool. Stool softeners, such as docusate sodium, do not stimulate the bowel or draw in fluid, but simply add moisture to the stool, making it easier to pass. These are often used post-operatively or in patients on opioids, where straining is either painful or contraindicated. Shifting to the other end of the GI spectrum, let's discuss antidiarrheals. These medications reduce bowel motility and help manage fluid loss, but they must be used cautiously. Loperamide, Imodium, is a common over-the-counter antidiarrheal that slows gut motility and allows for more water absorption in the colon. Bismuth subsalicylate, Pepto-Bismol, provides antimicrobial action and coats the stomach lining, but contains aspirin, so it must be avoided in children due to the risk of Ray's syndrome. Diphenoxylate atropine, Lomotil, is a prescription opioid-based antidiarrheal, and while effective, it carries a risk of CNS effects and dependency, especially if misused. Importantly, antidiarrheals should not be used in infectious diarrhea, such as C. difficile or foodborne illness, because slowing motility can trap pathogens in the GI tract and worsen the infection. Nurses should monitor for dehydration, electrolyte loss, and ensure fluid replacement as needed. Now let's turn to antiemetics, which are used to treat nausea and vomiting, common symptoms after surgery, during chemotherapy, or with motion sickness. Dopamine antagonists include prochlorperazine, promethazine, and metoclopramide. These medications work by blocking dopamine receptors in the brain, reducing the nausea center's activity. They are effective, but not without side effects. For example, metoclopramide can cause tardive dyskinesia, which is a serious and potentially irreversible condition involving involuntary facial and body movements. This risk increases with long-term use, especially in older adults. Serotonin antagonists such as ondansetron, granisetron, and polonosetron are considered the gold standard for chemotherapy-induced nausea and vomiting. They are also used post-operatively and during pregnancy. The main concern with this class is QT interval prolongation, which can lead to dangerous arrhythmias, so cardiac monitoring may be necessary, particularly in those with cardiac history or on other QT prolonging drugs. Finally, antihistamines such as diphenhydramine, meclizine, dimenhydrinate, and hydroxyzine are used for motion sickness and vertigo. These drugs work by blocking histamine receptors in the brain's vestibular system, but they commonly cause sedation and drowsiness. Patients should be cautioned against driving or operating machinery after taking these medications. Let's dive into one of the most high-yield topics in pharmacology: antibiotics and antimicrobials. These medications are essential tools in treating bacterial infections, but they also come with specific risks, interactions, and testable details you'll need to know for the NCLEX. Let's start with penicillins. These are the original antibiotics, most easily recognized by the "cillin" ending. They are bactericidal, meaning they work by destroying the bacterial cell wall. Penicillins are particularly effective against gram-positive bacteria, such as Streptococcus, Staphylococcus, syphilis, and meningitis. Some common examples include amoxicillin and ampicillin, which are often used for ear infections, strep throat, and pneumonia. Penicillin G and penicillin V are typically used to treat strep infections and syphilis. Piperacillin combined with tazobactam, better known as Zosyn, is a broader spectrum penicillin that also covers tough-to-treat pathogens like Pseudomonas. One of the most important concepts to understand about antibiotics, especially penicillins, is resistance. These drugs can be life-saving, but only when used appropriately. That means the full course must be completed, even if the patient feels better, to avoid resistance and superinfections. Patients must be monitored closely for allergic reactions, which can range from mild rash to life-threatening anaphylaxis. Always assess kidney and liver function, since these organs are responsible for metabolizing and excreting most antibiotics. Also check for potential drug interactions, especially with other nephrotoxic agents. A few high-yield reminders apply to all antibiotics. First, always assess for allergies. This is an NCLEX favorite. There's also a known cross-sensitivity between penicillins and cephalosporins, which we'll talk about in a moment. Most antibiotics carry the risk of causing superinfections, such as C. diff, thrush, or vaginal yeast infections. Many antibiotics are best taken on an empty stomach, typically 1 hour before or 2 hours after meals, and some can reduce the effectiveness of oral contraceptives. Anaphylaxis is another favorite test topic, so remember the sequence. Stop the drug immediately, call the provider, and administer epinephrine. Now let's move on to cephalosporins, which are structurally and functionally similar to penicillins. These drugs typically start with CF or cephs and are grouped into generations from first through fifth with increasing spectrum of activity. Like penicillins, they are bactericidal and work by weakening the bacterial cell wall. Common examples include cephalexin, a first-generation cephalosporin used for skin infections and UTIs. Ceftriaxone, a third-generation drug, is used for more serious infections like meningitis and gonorrhea. Cefepime, a fourth-generation agent, is frequently used in hospital-acquired infections, including Pseudomonas. For the NCLEX, it's important to remember that cephalosporins have a known cross-sensitivity with penicillins, so allergy history is critical. Patients should avoid alcohol while taking cephalosporins due to the risk of a disulfiram-like reaction, which causes nausea, vomiting, and abdominal cramping. Renal function should be closely monitored, especially in older adults. Cephalosporins can also increase bleeding risk, so if the patient is on warfarin, their INR should be monitored. Next, we have the macrolides, which end in thromycin. These drugs are commonly used for respiratory infections, chlamydia, and whooping cough. They are bacteriostatic, meaning they inhibit bacterial protein synthesis. Azithromycin, commonly known as the Z-Pak, is a popular choice for outpatient infections. Clarithromycin is often used in the treatment of H. pylori, and erythromycin is a good alternative for patients with penicillin allergies. Key NCLEX points include QT prolongation, which is a known side effect of macrolides. Always monitor ECGs, especially if the patient is on other cardiac medications. Macrolides are also hepatotoxic, so liver enzymes should be checked regularly. They should not be taken with statins due to the risk of rhabdomyolysis. Some patients may experience a metallic taste or nausea, which can be reduced by taking the medication with food. Let's move on to the fluoroquinolones, which end in fluoxacin. These are considered the big guns in the antibiotic world. They are bactericidal and work by inhibiting bacterial DNA synthesis. They're used for serious infections, including UTIs, pneumonia, and gastrointestinal infections. Common fluoroquinolones include ciprofloxacin, used for UTIs and even anthrax exposure, and levofloxacin, which is effective for pneumonia and sinusitis. Fluoroquinolones come with a black box warning for tendon rupture. This risk is especially high in older adults, athletes, children, and pregnant patients. Other side effects include photosensitivity, so patients must be advised to wear sunscreen and avoid tanning, and central nervous system effects like confusion and seizures. These drugs should not be taken with dairy, antacids, or iron, as these substances interfere with absorption. A key teaching point is to report any heel or leg pain immediately, as this could be an early sign of tendon damage. Now let's talk about the tetracyclines, which end in cycline. These drugs are bacteriostatic and also work by inhibiting protein synthesis. Doxycycline is commonly used for MRSA and Lyme disease, while tetracycline is often prescribed for acne and H. pylori. Tetracyclines should never be given to children under the age of 8, as they can cause permanent tooth discoloration. They are also contraindicated in pregnancy due to their effects on fetal bone and tooth development. These drugs should not be taken with dairy products, iron, or antacids. Space these substances at least 2 hours before or after taking the antibiotic. Tetracyclines can cause photosensitivity and increase the risk of esophagitis, so patients should remain upright for at least 30 minutes after taking the medication. Next, we have the aminoglycosides, which typically end in mycin and are administered intravenously. These are ICU-level antibiotics used for severe infections, such as sepsis and drug-resistant organisms. Neomycin is the exception and may be given orally for bowel sterilization before surgery. These drugs carry serious risks. There's a black box warning for both ototoxicity, characterized by tinnitus and hearing loss, and nephrotoxicity, so renal function must be monitored closely. Peak and trough levels should be measured to ensure therapeutic levels without toxicity. These drugs are never given orally, with the exception of neomycin. Lastly, let's cover the sulfonamides, easily identified by the sulfa prefix. These drugs are bacteriostatic and work by blocking folic acid synthesis. A commonly used example is sulfamethoxazole trimethoprim, or Bactrim, which is used for UTIs, MRSA, and pneumonia in immunocompromised patients. Patients must be advised to drink plenty of fluids, at least 2 to 3 liters per day, to prevent kidney crystals. Sulfonamides can cause photosensitivity and may lead to Stevens-Johnson syndrome, a rare but life-threatening rash that must be reported immediately. These medications can also raise potassium levels, so potassium supplements should be avoided. Sulfonamides are contraindicated in patients with sulfa allergies and during pregnancy. Let's move on to the emergency and critical care medications. Let's talk about some code blue medications. First up is epinephrine, the #1 drug used in a code. It's given during cardiac arrest rhythms like VFib, pulseless VTAC, asystole, and PEA. It stimulates both alpha and beta receptors, increasing heart rate, blood pressure, and overall perfusion. We give it every 3 to 5 minutes during CPR. It's also used IM for anaphylaxis, with IV dosing if the reaction is severe. Watch for tachycardia, hypertension, and palpitations once circulation returns. Next is atropine, used for bradycardia, especially if the heart rate drops below 40 beats per minute. It's an anticholinergic that blocks vagus nerve stimulation to raise the heart rate. We also use it in organophosphate poisoning and sometimes before surgery to dry secretions. Be on the lookout for dry mouth, blurred vision, and urinary retention, and avoid it in patients with glaucoma. Now let's talk about amiodarone. This is your go-to antiarrhythmic for ventricular arrhythmias, especially VTAC and VFib after an MI. It slows down conduction by blocking potassium channels, helping stabilize the rhythm, but it comes with serious risks: pulmonary toxicity, thyroid issues, liver damage, and QT prolongation. So we monitor lung function, liver enzymes, and the QT interval closely. If amiodarone isn't available, lidocaine is a backup. It works by blocking sodium channels, which slows down electrical conduction in the ventricles. It's helpful in VTAC and VFib, but not used for atrial arrhythmias. Now let's shift into shock management. When a patient is in septic, hypovolemic, or cardiogenic shock, and fluids alone don't work, we reach for vasopressors to raise blood pressure and improve perfusion. Norepinephrine, also called Levophed, is the first-line vasopressor for septic shock. It causes strong vasoconstriction, which raises BP quickly. But it can also cut off circulation to the skin and extremities, so it must be given through a central line to avoid tissue damage. We titrate the dose based on the patient's blood pressure and watch for signs of poor perfusion, like cool or mottled skin. Dopamine has dose-dependent effects. At low doses, it improves kidney perfusion. At moderate doses, it raises heart rate and blood pressure. And at higher doses, it strengthens the heartbeat, making it useful in cardiogenic shock or heart failure. But it's not used in hypovolemic shock, and it can cause tachycardia, so we monitor vitals closely. Dobutamine is more focused on improving cardiac output by helping the heart pump more effectively. It doesn't significantly raise blood pressure, but it's helpful in patients with low cardiac output. Like those in heart failure, it can also cause increased heart rate, so again, we keep an eye on vitals. Let's finish with respiratory crisis medications, starting with the rescue inhaler everyone knows. Albuterol. It's a fast-acting beta-2 agonist that relaxes airway smooth muscle and opens the lungs during asthma attacks or COPD exacerbations. It can cause tremors and tachycardia, especially if used in high doses. Always use albuterol before inhaled steroids so the airway is open for better absorption. We often combine albuterol with ipratropium, an anticholinergic bronchodilator. It's not a rescue med, but it works well in COPD and severe asthma, especially in combo inhalers like Duoneb. Ipratropium can cause dry mouth and urinary retention, so monitor for those side effects. Then there's magnesium sulfate, which we use when an asthma attack isn't responding to usual treatments. It works by relaxing the bronchial muscles. It's also a key drug in preeclampsia to prevent seizures. But it can suppress the nervous system, so we monitor for respiratory depression, loss of reflexes, and other signs of toxicity. If needed, we reverse it with calcium gluconate. Psychotropic medications are essential in treating mental health conditions like depression, anxiety, bipolar disorder, and psychosis. These drugs work by affecting neurotransmitters, primarily serotonin, dopamine, and norepinephrine, to stabilize mood, reduce anxiety, and manage symptoms like hallucinations or mania. Let's begin with antidepressants, which include four major classes: SSRIs, SNRIs, TCAs, and MAOIs. SSRIs, such as fluoxetine, sertraline, and escitalopram, are the first-line treatment for depression and anxiety. They increase serotonin levels and typically take 4 to 6 weeks to become effective. Patients must be monitored for worsening depression during the initial phase and for serotonin syndrome, which can be life-threatening. Selective serotonin reuptake inhibitors should not be combined with St. John's wort, MOEs, or tramadol. If SSRIs are ineffective, SNRIs like venlafaxine and duloxetine are often used. These increase both serotonin and norepinephrine and are especially helpful for nerve pain. However, they can increase blood pressure, and sudden discontinuation may cause withdrawal symptoms such as dizziness or brain zaps. TCAs such as amitriptyline are older antidepressants now more commonly used for neuropathic pain and migraines. They carry anticholinergic side effects and have a high overdose risk, making them less ideal for patients at risk of self-harm. MAOIs like phenelzine and tranylcypromine are last resort medications due to their serious food and drug interactions. They require strict avoidance of tyramine-rich foods to prevent hypertensive crisis and a 2-week washout period before switching to or from other antidepressants. Now, for antipsychotics used in schizophrenia, bipolar disorder, and psychotic depression. Typical antipsychotics like haloperidol block dopamine strongly and have a high risk of extrapyramidal symptoms, EPS, and neuroleptic malignant syndrome, NMS, a medical emergency involving fever and muscle rigidity. Atypical antipsychotics like risperidone and clozapine have a lower EPS risk, but are linked to metabolic side effects such as weight gain, diabetes, and dyslipidemia. Clozapine specifically requires weekly WBC monitoring due to the risk of granulocytosis. For bipolar disorder, the gold standard treatment is lithium, which requires close monitoring. The therapeutic range is 0.6 to 1.2 milliequivalents per liter. Levels above 1.5 milliequivalents per liter are toxic, with signs like tremors and confusion. Patients must maintain normal sodium levels and stay well hydrated, as low sodium or dehydration increases toxicity risk. Valproic acid, another mood stabilizer and anticonvulsant, is used for bipolar disorder, seizures, and migraines. It carries risks of liver damage, low platelets, and pancreatitis, so monitoring LFTs and platelet counts is essential. Taking it with food helps reduce GI side effects. In short, psychotropic medications are highly effective but come with serious risks. Safe administration requires understanding each drug class, recognizing red flags like serotonin syndrome or lithium toxicity, and educating patients about side effects, interactions, and the importance of adherence. The last topic of the lecture is reproductive and genitourinary medications, We'll start with oral contraceptives, used not just for preventing pregnancy, but also for regulating menstrual cycles, treating PCOS, managing endometriosis, and improving acne. Combination pills contain estrogen and progestin. Common examples include orthotricycline, Yaz, and Seasonique. A major NCLEX concern is increased clot risk, especially in smokers, patients over 35, and those with obesity. Patients should never smoke while on these medications. They're contraindicated in breast cancer, liver disease, migraines with aura, and uncontrolled hypertension. Missed pills should be taken as soon as remembered, but 2 or more missed doses require backup contraception. For patients who can't take estrogen, like those breastfeeding or at high risk for clots, progestin-only pills are a safer option. These must be taken at the same time daily. A delay of more than 3 hours means backup contraception is needed. Emergency contraception, such as Plan B or Ella, works by delaying ovulation and must be taken as soon as possible, most effective within 72 hours. These are not abortion pills and may cause cramping, nausea, or irregular bleeding. Now on to erectile dysfunction medications, which end in -afil and include sildenafil, Viagra, tadalafil, and vardenafil. These are PDE5 inhibitors that improve blood flow for erection. They are also used for pulmonary hypertension in some cases. A key NCLEX warning: do not combine these with nitrates, as it can cause fatal hypertension. Use caution in patients with heart disease. Side effects include flushing, headache, and priapism, which is an emergency if it lasts over 4 hours. Next, let's look at BPH medications. Alpha blockers like tamsulosin relax the prostate and bladder neck to improve urine flow. They can cause orthostatic hypotension, so patients should change position slowly and take the medication at bedtime to avoid falls. The second BPH treatment class is the 5-alpha reductase inhibitors, such as finasteride and dutasteride. These shrink the prostate over months, not days. They are teratogenic. Pregnant women should avoid touching crushed pills. These meds can also cause decreased libido or erectile dysfunction. In summary, focus on clot risk with estrogen, strict timing for mini pills, dangerous interactions with ED drugs, and the slow onset of BPH medications. Know the safety teaching points, and you'll be ready for anything NCLEX throws at you. Lastly, our pharmacology lecture notes wrap up with some important miscellaneous content, including antidote charts, high alert medications, toxic drug level charts, and 50 NCLEX-style practice questions with detailed answers, all shown here. But for the sake of time, we'll be skipping this section in the video. You're more than welcome to review those detailed notes anytime on our website. Now that we've covered the majority of the high-yield pharmacology topics from the notes, let's move on to practicing some NCLEX-style questions together. First up, a client with asthma receives multiple doses of albuterol during an acute exacerbation. Which assessment finding should the nurse expect? The answer is tremors and tachycardia. The rationale is that albuterol, while primarily a beta-2 agonist, can also mildly stimulate beta-1 receptors, especially at high or repeated doses. This results in increased heart rate and muscle tremors, which are common and expected side effects. Bradycardia, drowsiness, and respiratory depression are not typical with albuterol use. Next, the nurse is educating a client on lithium therapy. Which statement by the client indicates the need for further teaching? The answer is, it's okay to take ibuprofen daily for my back pain. The rationale is that NSAIDs like ibuprofen can interfere with renal clearance of lithium, leading to a higher risk of toxicity. Clients on lithium should avoid NSAIDs unless their provider specifically approves it. All the other statements reflect good understanding of hydration, toxicity symptoms, and the importance of routine blood level monitoring. A nurse is caring for a client on clozapine for treatment-resistant schizophrenia. Which of the following assessments is the priority? The answer is white blood cell count. The rationale is that clozapine carries a high risk of a granulocytosis, a potentially life-threatening drop in WBCs. That's why weekly or biweekly blood monitoring is required, especially early in therapy. While weight gain and metabolic effects are relevant, infection due to low neutrophils is the most urgent concern and takes priority. Next, a client with hypothyroidism is prescribed levothyroxine. Which of the following instructions should the nurse include? The answer is, take the medication in the morning on an empty stomach. The rationale is that levothyroxine is best absorbed without food, ideally taken 30 to 60 minutes before breakfast. It also needs to be taken consistently each day, and clients should understand that improvement takes weeks, not hours. It's a lifelong therapy and should not be stopped abruptly, even if symptoms improve. Which finding in a client receiving IV magnesium sulfate for preeclampsia requires immediate intervention? The answer is absent deep tendon reflexes. The rationale is that loss of reflexes is an early indicator of magnesium toxicity, which can progress to respiratory depression and cardiac arrest if not addressed. This is a medical emergency. The infusion should be stopped and calcium gluconate, the antidote, should be prepared. Mild flushing and elevated BP are expected findings in preeclampsia, and urine output of 35 milliliters per hour is still within acceptable range. All right, that was it for the Pharmacology Mastery Lecture Series. If this helped you out, don't forget to subscribe, like, and hit the notification bell so you don't miss Part 3 and all the other good stuff coming your way. And if you're looking for the detailed pharmacology guide notes from this lecture, head over to our website, yournursingspace.com. You'll find in-depth lecture notes, NCLEX-specific resources, and more tools to help you pass with confidence. For the Pharmacology Mastery Lecture Series. If this helped you out, don't forget to subscribe, like, and hit the notification bell so you don't miss any new videos and all the other good stuff coming your way. And if you're looking for the detailed pharmacology guide notes from this lecture, head over to our website, yournursingspace.com. You'll find in-depth lecture notes, NCLEX-specific resources, and more tools to help you pass with confidence. You can also check out our test bank platform, Exam ASAP, our advanced adaptive testing platform featuring over 5,000 peer-reviewed questions designed to mirror the NCLEX experience. It includes detailed rationales, daily content updates, and a 24/7 AI tutor, resources recognized as industry-leading and proven to enhance your performance. Not only that, our question bank platform has next-generation NCLEX question types with case studies. We are adaptive and AI-powered platform that allows you to pass the NCLEX the first try. With our question bank platform, you are able to see the analysis of how ready you are for the NCLEX exam with a detailed analysis based on your performance. So check out our website for all those goodies. And I hope this lecture helped you feel a bit more confident with the pharmacology section, whether you're studying for nursing school or gearing up for the NCLEX. Again, I'm Mark Johnson, your NCLEX instructor here at YNS, and I'll see you in the next lecture.